Maddie, what brings you in today?
So I've got the marathon coming up in 3 weeks' time, and I've noticed a pain in the side of my knee. I went and did my peak week, my longest run, about 10 days ago, and that was fine. Had a deload week last week in the rain, didn't run as much, but I've gone for a run yesterday morning and it's quite sore. I've noticed a lot of pain in the side of my knee. Not had it before, really dialed the load back this year compared to last year because I overdid it with everything last year, and just wanted to come in and get it checked, knowing I've only got 3 weeks to go.
So with the run that you did yesterday, did the pain come right at the beginning? Did it build up?
It built up. It wasn't straight away. And when I did my longest run a couple of weeks ago, I noticed my knee was sore afterwards, but it went away by the next day. It was just, I could feel it a little bit. It wasn't too painful. Whereas this week it's a lot more painful, and the pain has stayed since the run.
So as soon as you stopped running, the pain was still there?
Yeah, the pain was there and has pretty much stayed.
Do you notice it when you're walking, stairs?
Yeah, walking, and particularly standing after sitting for a long time. Stairs, not so much. I mean, walking in general, I can feel it,
Okay. And run me through an average week of running for you. How many runs are you doing? What's your short run? What's your long run?
So 3 runs a week, so Tuesday, Thursday and Sunday. So day in between. 2 strength sessions and 1 Pilates session a week. My biggest weeks, the last few weeks, I've been running about 60 Ks a week. So my shortest run, my easy run has been about 14 Ks. And my longest have been 30, 32 and then 34 was my longest one I did. And then this past week I've only run about 30 Ks, a deload week. Skipped a run because of the rain and didn't want to injure myself and slip over, so
Okay. When you got the pain, what did you do after it? Did you try Nurofen, ice? Did anything ease it?
Didn't really try too much. I mean, I ran into work and was straight in the office all day, had a massive day. So didn't really do too much. Cancelled Pilates this morning because I didn't want to go and aggravate it, and then just thought I'll come in and see you straight away.
Okay. You mentioned also last year that you sort of built up and there was an issue towards the end. So was it a similar issue? What was the issue?
No, so I injured my glute last year, so that was a muscular tightness issue. We treated that last year, acupuncture, dry needling, lots of stretching. I was in a lot more pain last year, could barely walk last year, whereas this year I can feel it and it's a niggle, but it's not. Yeah, the glute. Okay. The glute. I've done a lot of single leg work to try and condition that, and not get injured. Last year I was running 4 days a week, though this year I'm only running 3 days a week. Try to keep a lid on things.
No, good. Show me where the pain is on your knee.
Yep. So it's just down the side here.
Okay.
Kind of right on this bone, on the inside of my knee. So it's not
on the actual
knee, it's more on the inside.
Okay.
A little bit lower down.
All right. Do you mind if I get you lying on your back and we'll have a look at the knee and see what's happening? Let's first assess the overall knee and the leg. So feeling through the quads, feel pretty good. See that increased tone through your VMO, which is great. Just relax completely for me. Awesome. Okay. Kneecap, relaxing again. Try and relax. Good. All right, so kneecap's a bit still stiff. Let's get the knee bending first. Any pain if I do that?
No.
Okay, and a little more. Any pain there?
No.
Okay. How about pain on full extension here? Good. All right, a little bit of hyperextension there, which we tend to see. We'll do a little meniscal test first, just rule that out. So, any pain there?
No.
Okay, good. And on the other side?
No, that's fine.
Nothing there. All right, and just this side one more time.
All good.
Nothing at all. Good. Okay, come back down. Just examining through the patella tendon. Any pain when I'm pushing there? Okay. And what if I push on either side of the kneecap?
That's fine.
Nothing there. Any of those feel like the pain?
No, it just feels odd.
Does the knee feel unstable at times at all? Does it
No.
feel like it wants to buckle or give way?
No, I've had more issues with my ankles.
Yeah.
I used to play soccer years ago, so I've got dodgy ankles, but my knees, I've never had issues with my knees.
Okay, cool. I'll do just a stress test on your MCL. Given that you're not feeling it unstable at all, it's unlikely, but any pain there?
No.
And that's a good end feel. All right. So back to the pain. Sort of, is it at this point or a little lower?
A little bit lower here. Yeah.
Sort of like here?
There, yeah.
Okay. What if I go lower through here?
I can feel that's tight there. Yeah,
How about here?
a little bit, but it's a bit higher. Yeah.
Any pain on the outside over here at all?
No.
Okay. And what about if I really dig deep? So this is called your tib post. Any pain over there?
No, that's fine.
Yeah. Okay, so nothing through there. Really, kind of almost on the bone, would you say?
Yeah.
Yeah, right on there. Okay. So yeah, it's definitely not on the knee. When did you say your marathon was again?
3 weeks.
3 weeks.
Yeah.
Okay. In terms of nutrition, how's that all going?
Eat everything. Eat
Yeah.
everything inside.
Good. Calcium. Have you had a recent blood test or anything like that?
Not recently, but my iron levels have been low in the past
Okay.
when I've had my bloods done previously, but I haven't probably had one since the beginning of the year.
Nothing too bad. And if I recall, you said like just standing up there was pain, walking there was
Yeah.
pain. So it was kind of like always around.
Always around.
How about in bed?
No, I didn't notice it in bed.
So more like when there was load going
When there's
through
load on it, yeah.
Okay. So I would say given the amount of running that you're doing, it's quite high, like 60 kilometers a week. Do you know, are you heel striking, midfoot striking, unsure?
Unsure.
Okay, cool. So we tend to see sometimes some bone stress reaction issues with people particular who are heel striking. Essentially when you're heel striking and your heel is loading like that, the bone the stress of the running transfers into the bone, and we can start to see what we call a bone stress, which is essentially sort of like the internal bone starting to fracture. The best thing to do and to really get that diagnostic is we do an MRI. The MRI is it's like 4K resolution. It'll show us exactly what the issue is. Given that there's 3 weeks, and I know you've been training for this for a number of months, we really want to get it right. If it is a bone stress fracture, then unfortunately it means
It won't be.
yeah, we won't be doing the marathon because most fractures take 6 weeks to go. If it isn't, and there's a chance that it might not be, there is a bursa in that area and it could be something like that, then there is a chance that we could get it better. We also have other modalities that we could look at, things like shockwave therapy, cortisone injection, so at least we can try and get you through this run.
Yeah.
So how does it sound if we send you off for an MRI?
Yeah, sounds good.
Awesome, let's do that. Beautiful. All right. Hey Adam, how are you?
Good, Chris. How are you?
Very good, thank you. Thanks for giving me a call back. Did you get a chance to have a look at that marathon runner, Madeline?
Yes, I did. I have the images in front of me if you want to have a look at them together.
Yeah, beautiful. Which, are we in coronal, sagittal?
So bring up that coronal
Yeah.
1826.
Okay, going into 1826. Yep.
And the axial 2940.
And axial 2940. Yep.
So medial to posterior medial knee, there's a lot of fluid distending the bursa beneath the pes anserine tendons.
Yep.
And it looks like an acute bursitis in that region, which would explain medial knee pain.
Yep. And that's that sort of increased white signaling just inferior of the knee joint.
That's right.
Yep. Okay. Beautiful.
So that's our bursa. Now, the knee does have a little bit of extra fluid, so there is a small effusion.
Yeah, I can see that.
So that's just generalized fluid all around the knee. And we also see that in the patellofemoral compartment there is wear and tear in the cartilage,
Yeah.
chondromalacia, which can also be a cause of knee pain.
Okay.
Is it likely not an acute finding?
Yeah. With the pes anserine, would you recommend injection, cortisone, or not really? What do you think? She's running in 3 weeks' time. She's building up to 40 Ks.
So most commonly can be conservatively managed with anti-inflammatories, rest,
Yep, I saw all
and
that.
so on. Steroid injections can have a role in helping the inflammation settle down.
Yeah.
Particularly if there's a lot of time pressure, but needs to be in the context of a structured kind of physiotherapy program.
Yeah. Okay. fantastic. Anything else sort of concern or any other comments sort of on the knee?
No, I think the main thing is that there's no evidence of stress fracture, which is what you were worried about.
Yeah, beautiful. No, really, really good. Awesome. Thank you, Adam. I really appreciate it.
No problem. Take
No
care.
worries. Take care. Bye-bye.
Bye.
So, Maddie, I'm going to first run you through the report, and then I'll show you on the images. I've had a chat with Dr. Adam, and so I'll show you sort of what he noticed. So, if we go through the findings, so there's a bit of fluid in the knee, so that's the knee joint effusion. No acute fracture, which is incredible news. ACL, PCL are all fine. On the medial femorotibial compartment, the meniscus is good. Cartilage is well preserved. There is mild fluid distension of the pes anserine bursa. So this is where we think your pain is actually coming from, with surrounding oedema extending to the posterior medial knee. So what that means is on the inside, kind of wrapping into the back, is where we're noticing a bit of that pain, and it's radiating into your semimembranous tendon. There is also the overlying medial collateral ligament, which we tested on your initial assessment, but there doesn't look like there's any trauma. You're not noticing sort of any instability, and on the MRI, he couldn't see any issue with that. So for now, we do think it's a bit of an acute bursitis because you've been running a lot more. You've essentially inflamed this bursa. Lateral compartment was really kind of good. No issues there whatsoever. The other thing he did note, which I think is really good that we've had the MRI because now we can get on top of it, is a bit of a patellofemoral compartment issue. So what patellofemoral means is essentially you have your patella and your femur, and they articulate with each other as the patella goes back and forth. We tend to see people having wear issues on one side of the patella if there is a patella maltracking issue. So over here, it looks like you do have this sort of issue. And over here, he notes that there's a full thickness chondral fissure with mild subchondral oedema. So what that really means is your patella has been rubbing on the inside of that femur, of that femoral condyle. It's worn away a bit of the cartilage there. And when he says full thickness, you've essentially worn the entire cartilage in that particular section. And there is a bit of swelling within the bone. So subchondral means like a submarine below the surface. Subchondral means below the bone, or below the surface of the bone, there is actually swelling inside the bone there. Otherwise, yeah, so it's not too bad in terms of there's no acute fracture which is going to truly inhibit you. If we can get on top of this acute bursitis, I believe that you can get running. I did chat with Adam, and he said that there's a potential that we could use a cortisone injection. Do I really want to do that just now? Not really. I think let's just give it a little bit of time. Let's give it, sort of treat it with some conservative management. So I've given you or recommended some anti-inflammatories for you to do right now. You've been icing it 2 to 3 times daily. We'll utilize a bit of shockwave therapy also on that, and I think we should see some improvement. So the final remarks were no acute fracture, inflammatory changes with the acute pes anserine bursitis. And I think something post-marathon that we really want to get on top of is this patellofemoral chondromalacia. It does have the potential to lead towards arthritis within the knee. So there's a lot of ways that we can, work on that. How does that all sound?
Cool. I'm glad it's not a fracture.
Yeah, me too. So let's have a look at exactly what's happening within the knee. So, okay, let's just zoom through here. Okay, so once we zoom through here, you can see this is the back of the knee. You can see the 2 femoral condyles, the tibia over here, and the start of the fibular head. So that tells us this is the outside of the knee, this is the inside of the knee. When we look more towards the inside of the knee, you can see this increased white signal over here. So whenever we get white signaling compared to black, it indicates to us that there is fluid in that area. Now, some of the fluid's obviously going to be things like blood, but what we're noticing over here is this increased white signal over here, right where your acute pes anserine bursitis would be, and that coincides pretty much with where you're pointing sort of on your knee and where you're noticing the pain. If we do have a look also just within the knee, there is a little bit of increased fluid, so that's that knee effusion that he did note. And if we do have a look at a different screen, we can have a look at the patella issue that he also noted. So if you actually just have a look in the patella over there, see that white sort of opacity?
Yeah.
That's the subchondral edema that he's referring to. So like I said, anything that sort of white signal tells us it's fluid. And when we're getting a bit of white signal within the actual bone, we're starting to get that inflammation within the bone. So a bit of a subchondral edema. So that's sort of where we're at, I think, in terms of getting you through the marathon. Let's work through conservative management. Let's see how you go this week. I don't want you to run at all. Just completely deload. Regular icing, regular on the anti-inflammatories. Always make sure that you're taking food with it.
Yep.
And then let's touch base another time later this week. Awesome. Thanks, Maddie.
Thank you.
Good job.